Hi, everyone. I've been told that we have to start promptly, so thank you very much for those who've already been able to join us, and welcome to the GLOW webinar. The session today is on mixed methods research experiences, in particular from Malawi. So this is the first GLOW webinar that has been hosted from abroad, and many of the team are here with me in Malawi. So may I just, first of all, if we can just introduce ourselves. So I'm David Lissauer, Professor of Global Maternal Health here at Malawi Liverpool Wellcome Trust in Blantyre, South Malawi, and also with an appointment at the University of Liverpool. And if I can hand over to Linda.
All right, afternoon, everybody. My name is Linda Nyondo Mipando. I'm a lecturer in health systems and policy at Kamuzu University of Health Sciences. I'm a health systems specialist. Thank you, Moses.
Hi, everyone. My name is Moses Kumenda. I'm a postdoc social scientist based at Malawi Liverpool Wellcome Trust, but also Kamuzu University of Health Sciences in Blantyre, Malawi. Thank you. Let me hand you over to Catherine.
Hi everybody, my name's Catherine. I'm an academic clinical fellow in obstetrics and gynecology at Birmingham Women's Hospital, and I'm also a PhD student at the University of Birmingham. And I will pass on to Joy.
I think, sorry, are you?
Good afternoon, everyone. This is Joy Nambia on the side. I am a health systems specialist at the University of Malawi office.
So for me, there were some connectivity issues, so I'll just reintroduce Joy. It's Dr. Joy Nambia, the health systems specialist from UNICEF Malawi, based in Lilongwe, Malawi. And Laura?
Hi, I'm Laura Jones. I'm a senior lecturer in qualitative and mixed methods applied health research at the University of Birmingham.
Brilliant. So a really fantastic panel here for you today. And just to give some information about what we planned during the webinar. So first of all, we're going to hand over to Linda, who's going to give us an introduction to mixed methods research and give some illustrative examples from her own work. Then hand over to Catherine to give a perspective as a PhD student embarking on her journey into mixed methods research, and again giving some examples from her own work that was part of her PhD. Then over to Moses to talk about his work also in Malawi, and also to give some personal reflections on some of those realities around mixed methods research that perhaps don't make it into the final manuscript. Then Joy is going to talk from the perspective as an implementer and a policymaker. We're of course engaged in research because we want to make a difference to women's health and practice on the ground, and that critical link that we often don't talk about. So really looking forward to understanding from his perspective. And then at the end, for the whole panel, opportunity to ask questions. So as we go through, please feel very welcome to ask any questions ready for that Q&A at the end, and please post them into the questions box rather than the chat box. And then also just to let you know that the session is going to be recorded and will be available on the GLOW website online. We felt it may be helpful for some people if there are references from the webinar. They'll also be available separately at the end, and also Katie and Tista, who've done a fantastic job organising all of this, have also said they'll be happy to share certificates for attendees at the end as a certificate of attendance. So thanks very much for that. I hope Joy is back with us. I think one of the challenges from hosting this from Malawi is, of course, we're a little susceptible to connectivity issues, but hopefully everything's working well so far, and please bear with us if we have any challenges as we go through. So I'm going to hand over to Linda for an introduction to mixed method research.
Thank you so much, David. So I will give an introduction to mixed methods research. Next slide. So that just illustrates the different research methods that we're traditionally used to, the quantitative approach versus the qualitative approach. But then underneath it, what we're going to discuss more is the mixed method approach. If you think much more of a quantitative approach, one would be asking maybe only 1 in 30 take free ice cream, interesting. Whereas for a qualitative method, you would be asking, what did you feel when you saw the free ice cream? And they would go into the whole of that description. However, for mixed methods, then we're bringing the two methods together, and that's what we're going to talk about this afternoon. Next slide. So there are some core characteristics of mixed methods research that need to be abided to. Somebody has to oblige to those. So it involves the collection of both qualitative and quantitative data. So you've got both your open and closed-ended in response to a research question. It also involves analysis of both qualitative and quantitative data. It's also very persuasive and rigorous, detailing out the procedures for the qualitative and quantitative methods. You're essentially going to have to detail out the procedures for your qualitative side, as well as the procedures for the quantitative methods, nicely laid out. I usually say that it's like 2 protocols in one. It also involves the integration of these 2 data sources. So you could either merge the data sources at the end, or connect, meaning one source is leading to the other, or embed, meaning one source is predominant and the other one is just maybe a smaller piece. And these will come out later on as we go through some of the examples. It also involves the use of specific methods design that involves a combination, also a sequential integration. Sometimes you could have equal emphasis on the both methods, or an equal emphasis highlighting one the most. I love that cartoon when I came across it, because with mixed methods, it gives you this beautiful, beautiful bear. Next slide. So some of the reasons for mixing: you mix because you've got insufficient information. So it's the insufficient argument. So when you're at a moment where your quantitative or qualitative data is insufficient by itself, you might want to mix the methods so that you've got a fuller picture and a holistic view. The other argument is about multiple angles argument. So you want to aim for quantitative and qualitative approaches so that they're able to provide you with different pictures. So these will also come out clearly, I think, in the examples as we go on. There's also the argument that says the more evidence, the better argument. So you want to mix because there's more evidence. It will help you to gather more evidence, and that gives you a better argument in the long run. And again, for community of practice argument, because mixed methods is commonly preferred, especially now with implementation of programs, because it gives you a comprehensive view. Sometimes it's about intuitive, so because it mirrors real life, it allows you to do things according to the real life. Next slide. Some advantages, these are not all, so it gives you comprehensive data. It also helps one to study processes and outcomes as you go on, because you can move from one point, go through a transitionary period, and then you are able to gather much more information. It also compensates for limitations of using one method. So because you are using a couple, then at least you've got much more information that you can use. It also allows for investigation of different research questions. You've got various research questions. Some could be answered qualitatively, some could be answered quantitatively. So using mixed methods approaches helps you to do that. It also assists in investigation of complex research questions. Most of our health systems research is really complex, and mixed methods becomes ideal because it helps you to answer those questions in health service delivery, and also enhances credibility of your findings, because at least you're drawing your conclusions from multiple sources and various methods. So that enriches the credibility of the findings. Next slide. Even though it's got those beautiful advantages, appealing, it still has got some disadvantages that as a researcher you have to keep in mind. if the researcher is not adequately trained, the researcher's training would be a limitation towards that. Sometimes one could use one method superficially. So I think that stems as well from the training. It also requires extensive data collection, because you can imagine you have to collect data qualitatively and collect data quantitatively, and you have to be religious to both methods that you're using. It also requires more time and resources. As we go on, we realize that some of the methods require that you complete one part and move to the next with a bit of analysis in between. Sometimes it's got difficulties in report writing and forming conclusions. You can have contradicting results. Your quanti results could contradict your quali results or vice versa. And it may mislead, the findings might be misleading if there's no full integration of the data. Your data has to be quite well integrated, and the analysis bit becomes quite laborious, because you have to make sure that whatever you're communicating and concluding upon is really resulting from the full integration of the data sets that you have. Next slide. When should you use mixed methods? So you use mixed methods when you're trying to seek answers to the same question. So this is known as convergence. You're bringing in different ideas to the same question. You also use it when seeking answers to related questions, complementarity. So the questions could be related, but you want answers that are going to complement maybe the initial responses that you anticipate to have. And all these about convergence, complementarity will come again in the designs as well, because that's the basis or the platform for the designs. You also use mixed methods when findings from one method raises questions that can be answered by use of other method. So you want to expand the answers that you have and be able to gather more information as you go on. You can also use mixed methods when findings based on one method are a prerequisite to use of the other methods. If you want to develop a tool, an intervention, you'd want to do, first of all, maybe a formative phase, and then develop that intervention and then carry it through into another follow-up phase. So that would be the developmental aspect of it. Next slide. In terms of mixed methods, you could either also combine. So you combine the qualitative and quantitative approaches into the research methodology of a single study or multi-phased study. You could also mix in terms of timing of data collection. So it could be simultaneously happening at the same time. So you're collecting both your qualitative research, and then on the other side, you're also collecting your quantitative data. It could also be sequentially, meaning one after the other. So you could start off with your quantitative design, then transition, and then move to a qualitative design. There'll be examples that will be followed after this. It could also be in terms of weight or priority assigned to each method. You could assign priority towards your qualitative method, meaning the larger study that you're doing is a qualitative-based study. Or it could be quantitative method, meaning the larger study is a quantitative study. Or you could have equal weights distributed across between qualitative and quantitative methods. Next slide. So in terms of mixing, this is when I said will show up in terms of like, what can you do? So you can either merge the data. So you've got qualitative data, and then you also have quantitative data. So you merge the data at this point. You bring the data set from this point to, and from that point together, and then you make your interpretations. You could also connect the data. So with connection, you're starting off with qualitative data, then move to quantitative data, meaning that there's a point whereby you try to understand what is happening, or you analyze your qualitative data, then it builds up to the quantitative data, then you have your results and interpret, or the reverse where you start with quantitative data, move on to qualitative, and then the results. You could also embed the data. So you could have a big quantitative study there, but within it, then you have a qualitative data section as well. So a smaller section of it would have the qualitative data and then the results. Next slide. So these next slides will try to give some examples of what I've shared earlier on. So in terms of merging, so this is a convergent, in other textbooks, it's going to be called concurrent mixed methods design or convergent, you would have a quantitative data results and qualitative data set, and then the interpretation. So the results are matched for comparison and explanations. So a good example that I have there is that we've done a cross-sectional study that's looking at, a mixed method study, convergent design, that is looking at what are the strategies that we can use to optimize uptake of postnatal care amongst women and their neonates. So what we've done in that study, we've got a quantitative component, which was a review of a retrospective review of the postnatal registers for the mothers and the neonatal registers. So that is the quantitative piece. And then we've also conducted some in-depth interviews, focus group discussions with healthcare workers, mothers, fathers, elderly people in the population. Now we are at the point where we've brought up this data together. So we're looking at what's happening in the registers in terms of like receipt of postnatal care and neonatal care, as well as what is it that people are saying, the actual implementers and the recipients of that care. And the results are now merged so that we're able to compare and offer explanations. So that would be one example of a convergent mixed methods design. Next slide. Now, this is an example of an embedded design. So remember, an embedded design is a design meaning that one component is in the mix of the other. So what we have here would be a totally quantitative study. So the bigger picture is a quantitative study. This one follows a pre-test, a before and after. You've got a before pre-test data collection, and then you assume you're going to have an intervention, and then you have a quantitative post-data collection, and then interpretation. So the bigger study is a quantitative-based study, but we'll throw in a bit of qualitative aspects here during the intervention so that we collect more data regarding the intervention, and that's what makes it to be embedded, because the qualitative data, qualitative approaches are embedded within the quantitative approaches. So an example that I have is that you offer a pre-test on home management of depression in postnatal ward prior to training of caregivers. So that is done here. You do your cross-section study, you offer that pre-test. The intervention now is the training that you're going to offer to the caregivers. But then as you're offering that training, you are also gathering some qualitative data, maybe dependent on their how they accept or view the training that they are receiving at that point. And then you also end with a quantitative post-test, whereby you run a post-training and run the test again, then interpret all the results. The beauty of it is that you will not only have the results of before and the intervention and the afterwards, but you also have the data that is going to come out from the qualitative approaches, which is going to help you to say, if you're going to recommend to a policymaker to say, maybe you need to do this training, but you're also going to offer the issues that went along with that training as you're conducting it. Next slide. So those were the convergent designs. Now I'm moving to the sequential designs. So I'll start off with the explanatory design. With an explanatory design, you start off with the quantitative data or approaches. So you've got your quantitative data and the results, then you follow up. So you integrate it at this point whereby you're trying now to make sense of the quantitative data. You've got the analysis. Then from the quantitative data, you might want to follow up areas of special interest qualitatively, meaning you have done the quantitative approach, you have analyzed the data, you've got some questions that you still want to answer, and those questions can be better answered qualitatively. So you conduct a qualitative study and then you interpret your findings. Your findings are going to have both the quantitative data results as well as the qualitative data results, because it's going to give much more meaning that way. An example is that you could do a cross-sectional study on adolescents on their adherence to antiretrovirals. Then you follow up selected characteristics of adolescents and patterns of adherence in a qualitative approach to assess and gain deeper understanding. So you could run a cross-sectional study here. Maybe, let's say for argument's sake, your study sample size is going to be 340 adolescents. But then of them, you're going to run another qualitative study, which actually samples from those 340, you would have outlined what you want to study further qualitatively, having looked at the results that you have, having looked at the patterns of adherence that you have, that you'd want to explore further information from. So that would be a sequential explanatory design. So a sequential explanatory design starts off with the quantitative approaches, then you move to the qualitative approaches. Next slide. Then you also have sequential exploratory design. So the other one was explanatory, which starts with the quantitative approach. And exploratory design starts off with a qualitative approach. So you want to do this study when you don't have much information on what it takes maybe to improve something. So you're trying to explore what is there. So you start off with the qualitative approaches. Maybe you could do focus group discussions. Then you develop your intervention. At this point, having learned from what's there within the qualitative data sets, and then you move to the quantitative approaches, and then you interpret or integrate the findings thereon. So the example that I have here is about male involvement in prevention of mother-to-child transmission of HIV services. So conducted a study whereby my interest was really to find what did it take to involve men? What should we do? Because the argument has always been that if men are involved, there's a greater uptake of the services. So what we did was to do a qualitative an exploratory mixed method study. Started off with key informant interviews, in-depth interviews, and focus group discussions amongst men, women, and healthcare workers. After that phase, we analyzed the data because our main interest was really to find what are the strategies that we can use to involve men better. So this period of time here, that's when we analyzed the data and then looked at the data, then developed the intervention or strategy, which was done at this particular phase. And this strategy was developed, I guess, with information from the qualitative methods. Then that strategy was rolled out in a randomized controlled trial. So we developed a strategy that used an invitation card to the male partner, because they had suggested the use of an invitation card during the qualitative methods. So that invitation card then was rolled out into a randomized controlled trial. So this method helped us to be able to find out more in terms of like what is the best intervention in a moment whereby you don't have as many information or as much strategy that you can use at that time. Next slide. You could also have a sequential design that also has got some aspects of embedded design. The beauty with mixed methods is that it helps you to move from one point to the other, and it helps you to do things that the other standalone study designs might not be able to afford you with. So with this one, you could start with before an intervention is rolled out, you could do a qualitative assessment to see what is there on the ground. Then you have your quantitative intervention trial. Then you move on to, after the intervention, you could also do a qualitative study, and then you interpret. So in terms of an example, you can do a qualitative study on factors that influence screening for depression amongst pregnant women. So you do the qualitative assessment here, you assess for those factors. Then you develop a strategy to optimize the use of the tool. So that strategy, assuming that the tool is already there, but then people are not really screening the postnatal women, that's when you do the qualitative study. Then you try to develop a strategy to optimize the use of the tool. So the strategy could involve training, posters, checklists, and then you implement that strategy of training, posters, and checklists, implement it in the quantitative study, which is going to be an intervention trial, and you assess it for effectiveness while also studying implementation outcomes, like how is it working. Afterwards, you then can also conduct a qualitative interview among those you intervened upon and then interpret the findings. So it's embedded in a sense that even though it's sequential, moving from one point to the other, to another, but it's embedded because the quantitative study, it's embedded within this larger qualitative study that is seeking out to look at what is the intervention and what are the views regarding this intervention, but you also have the effectiveness bit aspect of it. then you interpret your findings, because then your paper is going to be much more richer, showing us what was there before the intervention, what was the intervention, and then what was it after the intervention. It takes us through the whole pathway. Next slide. All right, thank you very much.
Thank you so much, Linda. I think that was really fantastic. You know, I think after that, we all definitely feel comfortable that we know what mixed methods research and understanding this nomenclature and also the freedom, you know, and variations that you can use within a mixed methods approach. So thank you very much. I'm going to hand over now to Catherine, who's going to give us both her perspective embarking on mixed methods research as a PhD student, and then also give us some examples from her work. So yeah, thanks, Catherine.
Hi, everybody. Just to introduce myself again for some people who've joined a bit later, I'm Catherine. I've actually just submitted my PhD a couple of weeks ago, which involved 2 different mixed methods studies, and I'm an academic clinical fellow in obstetrics and gynecology in the UK. Next slide, please, David. So my PhD was looking at the prevention of how we can improve the prevention of maternal infection in global settings. And the aim of the PhD was to explore the global burden and the prevention of maternal infection with a focus on low resource settings. And this afternoon, I'm going to talk you through 2 mixed method studies that were a part of my PhD. One was exploring the acceptability and one was exploring the feasibility of implementing WHO guidance for infection prevention in maternity settings. Next slide. So a bit about me prior to starting the PhD. I was looking to develop my skills in both quantitative and qualitative methods, and I really wanted to conduct research in global maternal health. And before I started, I did have some prior experience in both methods, but this, the PhD research was the largest and most complicated project I'd ever done. And I had no experience of mixed methods research, but I was keen to learn about it. And I was really lucky because I started my PhD in a team that was already engaged in mixed methods research. Okay, so this is the first study I'm going to talk you through. It was investigating the acceptability of the WHO hand hygiene reminders in the workplace for use in maternity settings. And this is an example of a convergent mixed methods study. And these are the 3 reminders that we were exploring as a part of the study, which are the WHO standard hand hygiene reminders. Okay, next slide, please. And at the start of the study, we should just say that there weren't any reminders that were specific to maternity settings, which was partly why we had this question. So in order to do this study about acceptability, we used a framework, which it was written by Secon et al. It's a theoretical framework exploring the acceptability of healthcare interventions, and it includes 7 component constructs. We also launched a survey in 4 different languages, and we conducted qualitative interviews and a focus group with maternal health clinicians and public health practitioners. And this is a map that shows the countries that were represented in the end by the study, which was 48 different countries. And using this framework, we designed the survey and the qualitative data collection tools, and this was done to make sure that all the constructs were covered in both the data collection methods, so we knew we had information on every single construct from the acceptability framework. And quantitatively, the analysis was conducted by acceptability construct on Stata, and qualitatively, I did my analysis deductively, again by construct on NVivo. Next slide, please. So I'm going to give you examples from 3 of the different constructs. So the first one I'll talk to you about is effective attitude. Effective attitude refers to how the participants felt about the intervention, which was the hand hygiene reminders. And in these boxes, the percentages mean how many of the participants from the quantitative results said that they thought they were good or excellent in the survey. So effective attitude was one of our lowest performing constructs, and 70% of the participants said that they were good or excellent. And then I've presented here a quote, which is a summary quote of the kinds of things that people were reporting qualitatively in this construct. And they said, there is nothing here that relates to people in maternity settings. It looks like an ITU, and I don't work in an ITU, so it's not my business. And then comparing that, we have the intervention coherence construct, which is a construct that defines how well the participants understood what they were supposed to do in the intervention. And here, 91% of participants felt that the hand hygiene reminders were good or excellent in this construct, and it was our highest performing construct. And then an example quotation says, because in my country, some people are still illiterate, so if they can just follow what the pictures are saying, they can know what to do. And that was referring to the hand hygiene reminders where the pictures of how to wash your hands really demonstrate exactly what each person needs to do at each step. And we also had another construct of other, which we added to make sure that we didn't miss anything that came up outside of the acceptability framework. And this is an example quote from that, which says, we also need something that speaks directly to the patients. I think that would be a collaborative effort to stop the infection from spreading. So a lot of our participants said they wanted something that was also relevant to the patients, not only healthcare workers. Next slide, please. Okay, and this is, in the end, as a result of this study, 2 more reminders were developed specific to maternity care, aiming to be acceptable for maternity care settings in both high and low resource settings. And this is an example of one of the reminders, which is now available on the WHO website. And our overall findings were that the hand hygiene reminders were well received by the healthcare workers, but acceptability for maternity settings could be improved with adaptations, which is why we went on to do the adaptations. Okay, next slide, please. So I've tried to include these slides at the end just to explain how the study went from a mixed methods perspective. So this was quite a simple and specific research question. So deductive analysis and application of the acceptability framework felt appropriate. And actually using a framework with those specific constructs simplified the data collection tool design, the analysis, and the integration of results. And we were also able to draw recommendations from each component construct, which was beneficial. And we use the qualitative data collection additionally to explore some of the unclear results from the survey. So quite a lot of people in the survey said that they felt that a woman should be depicted in the poster. And so we used the qualitative data collection to explore that a bit further to make sure that if we included a picture of a woman, she would be culturally appropriate and dressed in a way that was acceptable in lots of different settings. But there were some downsides from doing it this way. So using the deductive qualitative analysis limited possible depth of exploration of this qualitative method. But to try and address this, we added an additional construct of other to make sure that we didn't miss findings that didn't neatly fit into the framework constructs. Okay, next slide, please. Okay, and this is the second example of a mixed method study that I'm going to present from my PhD. And this was the main bulk of my PhD work, was a feasibility study called Preventing Maternal Sepsis in Low Resource Settings. And this is an example of an explanatory sequential mixed method study. So just to recap, is we had quantitative data collection and then we used qualitative data collection to explain the quantitative results. Next slide, please. So the aim of the study was to look at how feasible it was to implement the WHO guidance for infection prevention in maternity settings. And the 3 primary things that we were looking at were implementing the WHO 5 moments for hand hygiene guidelines, implementing the WHO antibiotic prophylaxis guidance for cesarean section, and implementing WHO guidance for vaginal cleansing prior to cesarean section. And this afternoon, I'm going to talk to you about outcome 2, implementing the WHO antibiotic prophylaxis guidance. And just in case anybody isn't aware, the WHO recommends that every woman undergoing a cesarean section should have a single dose of antibiotic prophylaxis within 60 minutes prior to a skin incision. Okay, so the Proctor framework, which is another framework that explores feasibility of implementation research, was used to plan the data collection to make sure that we had a comprehensive understanding of feasibility within our results. Quantitative data collection used healthcare worker observations of hand hygiene opportunities and notes reviews of cesarean sections and other invasive procedures in 3 low-resource maternity settings in Malawi, and we used those results to determine percentage adherence to the guidelines. And then qualitatively, we explored those results using 33 semi-structured interviews with healthcare workers, and then again, a further step of 6 member validation exercises. Next slide, please. Okay, so as I've already said, this was an explanatory sequential approach. Qualitative data collection was used to explore and explain the quantitative results. And then member validation exercises were used to confirm or refute the findings from the qualitative data and add perspectives if this was needed. And this helped to make sure that we had an accurate understanding and representation of the qualitative results. And this time I did an inductive analysis of the qualitative results, and I integrated initially around the primary study outcomes, which I've just presented. And right at the end of the study, I used the Proctor framework again to integrate the results in a summary table. Okay, next slide, please. Okay, so these are the actual results. So we included 484 cesarean sections in the quantitative, just across those 3 sites in Malawi. And we did find that there was an improvement in antibiotic prophylaxis at cesarean section, which went from 75% in the baseline phase to 94% in the intervention phase. And that was a statistically significant improvement. However, we additionally found unexpectedly that over 90% of cases received a course of 2 or more days of antibiotic prophylaxis for cesarean section in both phases of the study, which isn't, it goes against the WHO recommendation, which is just for a single dose prophylaxis. So then this finding was then explored in the qualitative work, and 2 themes were inductively developed from the qualitative data to help explain these results. And the first theme was study context, and the second theme is characteristics of the intervention. Next slide, please. Okay, so I'm going to present just a brief summary of how the qualitative results explained that finding. So in the study context, we saw that in these 3 centres in Malawi, it was a national priority in Malawi to address maternal death. And that was the healthcare workers' background perspective going into the study. And they had strong concerns about the inadequacy of their water and sanitation and hygiene infrastructure in the hospitals and the simple realities of the hospital setting they were working in. So antibiotics in these sites was more readily available to them than running water. They were also concerned about the patient education and hygiene, because in this setting, the vast majority of the women would go home to a dirt floor. They didn't have a private toilet, and the healthcare workers were very worried that they wouldn't be able to keep their wounds clean and that kind of thing. And just as by way of explanation, in these settings, none of them had a laboratory facility on site. So for them, they knew about antibiotic resistance, and they were aware that it was an important thing to be concerned about, but it was an abstract concept because they didn't have the ability to test any of their cultures and see if they had a problem with resistance in their setting, whereas they did see maternal deaths, and that was a lived reality for them and something that was very upsetting and that they really wanted to prevent. And then when you look at the characteristics of the intervention, the healthcare workers were concerned that the evidence for this single dose prophylaxis actually came from sites that were quite different from theirs, from Western settings or from tertiary centres in low resource settings, which was different. They felt that those settings wouldn't be the same as theirs, and they didn't feel confident that the evidence would apply in their setting. There was also a lack of site consensus about whether to adopt this practice. So some individuals who did want to try it would later be overridden by other team members who weren't so confident and decided to prescribe the antibiotics anyway. And we had a general issue within the study that we were relying on documentation to determine some of these outcomes. And sometimes there was a lack of stationery, which made documentation quite difficult within the sites. Next slide, please. So this is an example quote which just helps to explain some of the issues that came through in the qualitative analysis. So it's an old building with no ceilings. Look at our theatre the way it is here. It's not in good shape. It's not clean enough. It has got a lot of openings to the outside environment, which gives a room for infections to get in. We don't have the gowns, so sometimes we usually improvise, maybe even the things that are not sterilised. We didn't have electricity. Even in our postnatal, we don't have clean linen to cover these women. Those could be the issues to think that maybe it should be a routine thing to give antibiotics even after the procedures. Next slide. Okay, so in conclusion, this study found that there was a complex issue of simultaneous over and underuse of antibiotics in this low resource maternity setting. And using mixed methods allowed us to comprehensively and deeply explore this unexpected finding, and which will be used to inform the implementation of a multi-country RCT going forward. Next slide. Okay, so practical lessons for me from this study was that this was a complicated and wide-ranging study, and it ended up exploring multiple topics, including individual concerns, team dynamics, the local healthcare setting and the healthcare system, in order to answer the research question. And because we used an inductive approach to the qualitative analysis for this study, it allowed exploration of the topics in depth. And I did feel by the end that we did understand the reasons why aspects of the study were and weren't feasible by the end of the analysis, which was really positive. And I think the main benefit was that we were able to include unexpected results that weren't planned to be addressed. And if we hadn't chosen to use mixed methods, we definitely would have missed some of these things. And we were able to then use that for a future RTT scale up. But the downsides were that it was really complicated and quite time consuming to conduct this study. And in many ways, I feel like it's opened up more questions than it actually answered. Next slide. Okay, so I'm just going to end with a few reflections on the use of mixed methods research in my PhD. So firstly, the benefits. I would say mixed methods were especially beneficial when things didn't go as planned, and this often turned out to be the most interesting and useful findings in my thesis. It was really important to me to be able to include the voice of the study participants in the results, and I was very happy that I was able to do that because of the use of mixed methods research. So personally, I gained experience in quantitative and qualitative data collection and 2 different methods of mixed method study designs and types of integration. So for me, my skill development has been maximized because of use of mixed methods. I found the work really satisfying because I feel like I was able to answer my research questions and understand why things did and didn't work. And I would definitely want to go on to use mixed methods research in the future because of this experience. Okay, next slide, please. So the challenges. So because you have to use qual and quant, it requires knowledge of multiple methodologies. There are more time constraints from using mixed methods because there's more than one data collection and analysis method, and then integration is an extra step, and it's a really critical step, so time needs to be allowed for that too. There are additional decisions to be made with using mixed methods research, so you need to think about how you want to integrate, as this will impact your study design, data collection tools, order of data collection, and your analysis. Mixed methods research produces a large volume of data, which at times felt overwhelming and was difficult to sort through and order, but we did get there in the end. word count. So additional methods means there's more to write. And finally, publication. Journals are becoming more receptive to mixed method studies, but they're still the exception rather than the norm. Next slide. So finally, for any PhD students considering mixed methods research, I would say it's beneficial to have supervisors with experience in quantitative and qualitative methods, ideally mixed methods too, if possible. I would say try to allow time for additional skills that you might need to develop to complete mixed method studies. So think about any gaps in your knowledge or experience when you start, including things like analysis software, because that can take a little while to get your head around. And remember to include time for the extra step of integration. And my final tip would be decide early on how you want to use each method and integrate your findings. Thank you very much.
Thanks so much, Catherine, both for sharing your amazing work, but also those, I think, insights that are so good because you don't understand all of those challenges and considerations when you just see the polished manuscript. So thanks for that. And to hand over now to Moses, who's going to share some insights into his work around social harms and HIV self-testing in general, and how he's used mixed methods research in Malawi.
Thank you very much, David, and thanks everyone for this opportunity. So I am going to talk to you about two studies. The first study is a study that we conducted on exploring social harms within the context of HIV self-testing in Malawi. So basically, we wanted to kind of, describe the social harm events reported during the implementation of HIV self-testing over about 6 years period within the context of HIV self-testing in Malawi. So basically, this one we use more or less like an emergent approach or convergent design. It's a mixed method approach. I think that's what that has been highlighted earlier by Linda. So what we did was, there was implementation of a lot of HIV self-testing sub-studies within the context of the STAR project. This is HIV self-testing Africa project. A slide, yeah. So in this project, there were, several studies that were implemented, but I think we realized that no study really went to the bottom of, understanding the social harms that are associated with HIV self-testing. So what we did basically was within the distribution of HIV self-testing, we kind of implemented both quantitative studies, which are actually outlined there, the ETB study, HIV self-testing impact, partner-assisted HIV self-testing and linkage, the PRISM study, the STAR general population study, and STAR female sex workup study. And within those, we also implemented the qualitative studies, which use basically the focus group discussions, the in-depth interviews, the key informant interviews, as well as the critical incident narratives. For the quantitative methods, questionnaires were used, as well as household surveys, but also active follow-up of cases of intimate partner violence, even death. Yeah, so we basically used an approach or a framework that was modified from the Division of AIDS table for grading the severity of adult as well as pediatric adverse events. Next slide, please. So this slide just outlines a framework that was modified for our context just to help us grade different levels of social harms linked to HIV self-testing. And those that were graded between 3 to 5 were kind of considered as severe or life-threatening social harms. Next slide, please. Yeah, so from the results, what we noted was that after distributing about 180,000 HIV self-test kits within the Malawian context, we noted that from the studies, only 25 were kind of categorized as, serious social events, which to us, we concluded that HIV self-testing didn't have or didn't exacerbate the problems of social harms. Because if you remember, I think at that time, people were really worried, even policymakers were worried that the introduction of HIV self-testing might actually bring about a lot of social harm. So these studies collectively showed to us that there were limited number of social harms. So we didn't have any reported death. We didn't have incidents of self-harms, but we had one case where a person had a suicidal ideation after self-testing for HIV. And again, we also noted from those studies that there was a high risk of separation, especially in HIV serodifferent couples. So marriages will break up or would be kind of destabilized if they were in serodiscordant relationships. So from the if we look at some of the emergent social harms which were not that severe, and one of it was coercion to test or disclosed. So you can see that here we just report quantitative results from the two studies that captured those variables. So in the HIT-TB study, we noted that there was about 2.9% of the people who actually said that they were coerced to either test or disclose. And we found that coercion was largely higher among men than women. And I think this explains the reason why you find that most women would have already had an HIV test within the routine care than women. So we also noted that among key populations, especially the female sex workers, there was a lot of high coercion from the employers, but also the peer distributors, or these were the people who were actually distributing the HIV self-test kits among fellow female sex workers. So that in itself also showed that I think in this category of people, can you go back, please? A slide, yeah. Yeah, so in this key population, there was elevated levels of coercion to disclose or to test. And what we noted from our qualitative results was that most of coercion that was reported, most participants viewed it as well-intentioned or socially reasonable. So they didn't see it in this context as something that was really harmful, but something that was really aimed at actually helping somebody who to actually, test for HIV or to actually start treatment. So you can see in the quote below there, when somebody said, when I got the kit, it took days for me without testing. Then my wife said that I won't eat that day if I don't test. So you can see that this is more or less like a wife is forcing a husband who was a little bit hesitating to test for HIV for him to actually test for HIV. Can you go to the next slide, please? So now I'm going to talk about another study, and this was a study that was funded by the Gates, and it was just looking at the blood-based HIV self-testing, just to test to find out the feasibility, but also the acceptability of HIV, blood-based HIV self-testing in Malawi. Next slide, please. So basically for this study, we use the mixed methods approach. Kind of use several test kits in the study. So there were two blood-based self-test kits. These are BioSure and ISTI, and the one oral fluid test kit, OraQuick. Next slide. So as Linda mentioned earlier, I think this one was more or less like an exploratory mixed method study. And this study was more or less like mixed at the level of a program. So you can see that at first what we did was, first of all, to test whether or not the instructional materials that came along with the HIV self-test kit would work within our context. And to do that, what we did was to do cognitive interviews, which were, done iteratively. So at different phases, just to test whether or not the instruction for use would work in our context, whether they were translated well, whether people would understand them. If they didn't understand the IFUs at the first time, then we would review them, then test them again. And after the first stage of cognitive interviews, we did an observation performance study, and this one just to see whether or not the revised instructional materials would work in our context. And this one was more or less like a quantitative study. And embedded within that was a qualitative process evaluation where we used about 8 FGDs and about 30 in-depth interviews. From there, we had a head-to-head comparison of the best performing HIV test kit from the observation study, and in this case was the INSTI and the oral fluid study, oral fluid test kit, which was OraSure. And then we went further to do the ART analytical accuracy study just to test the sensitivity of oral fluid and blood-based HIV self-testing against the reference standard. Next slide, please. So I'll just bring you a flavor of, two areas of our studies. So the cognitive interviews, what we learned from the cognitive interviews, then what we learned from the performance study. So for the cognitive interviews, you can see that the qualitative research actually identified several areas that needed to kind of change before we use the instruction materials within our context. And one of the problems you can see, there was actually a hand dryer in one of the instructions that said you wash and dry your hands. And to dry your hands, you needed, they showed a symbol of a hand dryer. And in our context, the use of the hand dryer, people didn't understand just that symbol, what it means. And therefore, we needed to change that symbol to make it contextually appropriate. Again, there were also issues to do with, the kits came with one lancet, and sometimes because some people were really working using these manual ladders, so people complained because one lancet could not be sufficient to prick maybe a finger. Then they complained to say, okay, if one lancet failed, then the whole test kit would fail. And also a need for an extra cotton swab to make sure to manage excessive blood. I think that was also something that was mentioned. There were also several problems with the illustrations, and one of the problems that I've already highlighted was the use of a hand dryer to dry your hands. Next slide, please. Yeah, so for the observation performance study, basically we recruited about 803 participants with a non-HIV status and who did not have a prior HIV self-testing experience in a rural setting and also an urban setting. And as you can see, because of some of the issues that were kind of highlighted from the cognitive interviews, we did have a bit of problems with the invalid results, especially for the INSTI self-test kits, but also there were also equal invalid results from the BioSure because maybe they didn't collect sufficient sample of blood, or the procedure they didn't follow the procedure correctly. But I think most of the people were able to perform the procedure well, but if it hadn't been that we had the initial cognitive interviews, I think we would have had serious problems with the observation performance studies. So I think we kind of had a benefit of refining the instructions for use for people to actually self-test themselves without an aid of a trained counselor. And you can see here, the people preferred to self-test without a counselor, about 63%, but others said, okay, we need a counselor. And that's also what explains the issues that they experienced with the invalid results. But the highest proportion of participants actually said that they would recommend, blood-based HIV self-testing to another person. Next slide, please. So now let's just highlight about the benefits of using mixed methods within the HIV self-testing studies. Firstly, what we noted was that I think these approaches, combining these approaches, was a very powerful tool for the STAR project really to get to the bottom of very complex issues and the issues that were at that point in time not explored. It also allowed the whole STAR team to influence the normative guidance both at the national level within the Malawian context, but also globally. But I think some of the challenges, I think we echo some of the challenges that Catherine highlighted earlier, issues of problems on publishing, papers that contain both qualitative and quantitative methods. The problem that usually in our context, we noted that quantitative findings were more impactful and more useful for people than qualitative, in that when you are actually going to a seminar, if you just present qualitative results only, they will say, oh, where are the figures now? So that actually meant that I think the power that was with the quantitative was actually higher when compared to that of qualitative. Again, the issue of merging sample sizes or findings from different data sets is something that was actually a little bit struggling for us, but I think we kind of tried to navigate it because I think we had a framework that we used to actually categorize these social harms. Yeah, so let me just stop there in the interest of time. May I hand you over to David?
Hi, and thanks so much, Moses, for that fantastic presentation and, coping very well with some background noise that was trying hard to knock you off your flow. I'm just going to hand over to Bijoy now. I'm really interested to get his perspective as a health systems technical specialist for UNICEF Malawi. Thanks very much.
Thanks, David. I hope I'm audible.
Perfect.
Great. If you can go to the slide, please. Thanks, everyone, and welcome all. Fantastic, high quality presentation so far we have had. And so what does this mean for policy and practice, all the evidence that we have gathered here? And I'm going to provide the implementer's perspective. In the interest of time, I'll keep it very short and simple. And from implementation or a policymaker's point of view, I'm sorry if I'm bursting a bubble here, but in many ways, implementers and policymakers are in some way agnostic to the research methods. And sorry to say that, but that does not mean that it's not important. The mixed method research per se might not affect them, but what is important is that they're keen to use the evidence for program implementation. And that comes from academics like all the distinguished panel that has been here presenting, from people like those that we look for evidence. But when we look for evidence, we are not looking just at the overall certainty of evidence of effects. Not just for a binary yes or no, but we want, when we are looking at implementation, we want quite a few other questions answered. Next, please. So we want to understand the benefits and harms. We want to look at the uncertainty and variability on how people value the main outcomes. What would be the impact on health equity? Is the option acceptable to stakeholders? Is it feasible to implement? And so on and so forth. So these are some of the, actually this is from a framework on evidence to decision making. Sorry, David, I didn't add the reference here, but perhaps when we share the slides, we can add the reference here. So just to summarize here that, while it is in many ways we are agnostic to the methodology per se, the evidence that we are looking at, a mixed method research is most suitable for that. Next slide, please. So we want to research that taps into the black box of interventions is more helpful for implementers. And as I said, mixed methods is best. It's no point just saying that intervention works or not. That's not really helpful for the implementer. We need to understand what goes on, everything that goes on in between. This is mainly because interventions in the real world are not functioning within a vacuum, right? We need to understand, next please, we need to understand the context in which things are operating. So we have, for instance, different layers of the context that we can think of. So there is the micro level, meso level, the exosystem, and the macro system. And it's not just understanding these individual, interpersonal, organizational, or health system levels, but also understanding the interactions between them. And that's where a mixed method research can be really helpful. Next slide, please. And so this is a real life example from one of the projects that I've just kickstarted last month, actually. This is a FCDO funded health system strengthening program, which is looking mainly at the two extreme corners, mainly at governance and accountabilities. That is where the program is focusing on. But in terms of impact, what the program tries to measure is maternal mortality and newborn mortality and under 5 mortality. And so that's quite a big reach, if you may see that how does this governance and accountability mechanism in a health system actually impact on, say, newborn mortality. And so it is not just looking at governance or accountability, but also the interaction between these different levels, the systems, the organization, the individual levels. We need to look at them in isolation, but also the interactions between them. And that's where mixed methods can be really helpful. Next, please. And I think this is very important to understand because, giving a binary response normally doesn't get us funding. Even if it is a negative response, we need to be able to explain very clearly why is it that we saw an effect, or why did we not, how did an effect come into being, or why did we not see an effect. And the other thing that the reason why mixed methods is helpful is we are dealing in the area that I work in terms of health system strengthening. We are dealing also with a lot of complexities, right? Distal causal relationships, long implementation chains, path dependence, non-linearity, and the like. Intervention effects, tipping points, where things are not 1 + 1 is not 2, it can be 1 + 1 can be 10. And so we need to be explained that we need to be able to explain that. And mixed methods is best suited for that. So yes, while just to conclude that while we are not so much concerned as at mixed methodology per se, the evidence that we are looking for, mixed method is best suited to provide that kind of evidence. So that's from my end, David. Back to you.
Thanks so much, Bijoy, for that, and I think really helpful to get that perspective. And I didn't say, but I mean, you've worn a couple of hats, because I know that you've also been a researcher in the past and used these techniques as a researcher. So lovely that you can offer both those perspectives. We're just going to now, we still have time, fortunately, for some panel questions, and it's great seeing all the questions that are coming in. I don't know if we'll get to all of them, but we at least get through some. And thank you also, Laura Jones, who's been busy responding to some of those questions as we've been going through. And it's really great to see all those comments in the chat and to see this diverse audience that we have here listening to the seminar. Can I just start off? I wonder if the panel will be able to switch on their videos and unmute, and let's hope our bandwidth can cope with it. So first of all, can I just go and give everyone the opportunity to really, for those who are just embarking on their mixed methods research careers, would you give a couple of your top tips, the things that you wish someone had told you before you started as a mixed methods researcher? I'll start with Laura, because you've been too busy typing and we've not heard from you.
Yeah, so I think my top tips would be to read the literature. The methodological evidence base around mixed methods is evolving and advancing all of the time. There's some really good books. Somebody asked us about books, and most people will know that I imagine the Creswell and Plano Clark books. Always tend to recommend them to students. And there's a number of journals now that are really focused on publishing methods and methodological debate about mixed methods. So have a look at that. The other thing I would think about is, just because lots of people are doing it and doing mixed methods, and that seems to be the hot topic, doesn't mean you have to do it. So think really carefully about what your research questions are and whether mixed methods is the right way to go. It might be that a multi-method study where you don't integrate the data, we might come on to integration a little bit. You know, don't think that you have to do it. You know, make sure that it's the right methodological approach for your research questions and the skill set and the resources that you've got.
Thanks. May I go to Linda?
For me, I think what I should have been told then was that it's going to take me through valleys and highs, but to also enjoy every moment, because when you're doing a sequential, some aspects are going to be much easier, but some aspects are going to be harder, but it doesn't stop you from doing it. As Rola has said, the question that you're trying to answer to really gives you the energy to go through all the phases of those of what you've proposed to do. Thank you.
Thanks. Catherine, Moses.
So my top tips would be to think early about how you want to integrate the data, and that does depend. There's been quite a lot of questions about this in the chat, so I'm sure we'll get onto it a bit more deeply, but it does depend on your research question and what the purpose of the study is. But I wish that I'd thought more deeply about that earlier on. And then my second tip would be choosing your supervisors wisely. So I was really lucky because my supervisors were David and Laura, and they both already involved in mixed methods research, and that was definitely really helpful for me.
Moses?
Yeah, so for me, basically, it's that aspect of surprises. Usually when we are doing mixed methods, sometimes you might start with this question and you would find that, you know, another interesting question or complex question is coming up. So maybe also the element that you should try to also tap on other people's skills when you are not very good with one of the methods, because sometimes we are good in one method than the other. So don't be afraid to tackle the question because you don't have the skill set, but also maybe try to make use of, you know, the people who maybe knows that field better to help you, you know, address the question that you want to answer. Thank you.
Bijoy, you can answer this with your researcher hat on or your implementer hat on, however you want, but any tips greatly received.
I think for me, it's something very much basic, and I think it's simple, but most often we can forget. I think what you need to place first is the research question, and then the methodology. More often than not, because you're affiliated to a certain school or a certain like thinking, methodology comes first, and then people try to retrofit sometimes the question into that. So if you're doing, say, for instance, a women's intervention, and depending on what the research question is, it can be qualitative or quantitative or mixed method. But if the principal investigator is RCP specialist or RCP, from RCPs, then they try to phrase the question to suit RCP. And I think that is a real flaw because it really doesn't help from an implementer's perspective. You might have answered the best question, but that doesn't give us much implementation. So I think having the research question clear first and then deciding on the methodology. I think it's very basic, but sometimes we tend to forget that.
Thanks. Sorry, I think you were breaking up a bit, Bijoy. I'm going to just stop the screen share in case that helps with the bandwidth. The next time when you're speaking, perhaps we'll switch off our cameras just so we can try to improve that. From what I could catch Joy. If others could hear better, apologies. But the key point was for you, the question is, the king or the queen, and that's what's critical, and then seek the appropriate methodology for your question rather than being fixed on one, and recognizing that even with, gold, standard evidence of an RCT, you still need to understand the context and why it, will or won't work in diverse settings.
Exactly.
I hope I paraphrased okay.
No, you got it right.
Good. So I wanted to move on to another question I think many people have touched on, but clearly key characteristic is the way that we are able to integrate the qualitative and the quantitative data. And I think it would be just helpful for people to emphasize some, again, either tips or their experience of approaches that they've used for this integration element and what works well. So I won't pick on anyone, but I wonder if anyone's willing to speak a bit more about the integration aspect and advice, because as Catherine, I think, pointed out, this is one of those areas that's challenging and requires careful preparation and planning even at the design phase.
I can say something if you like, David. We'll start off and then feel free to chip in. So I think kind of integration is the hallmark of mixed methods research, and how you do that is challenging, and it can be done in lots of different ways, and the methods are evolving. I think the thing for me is about kind of the visual representation of those data, and is there a way, kind of, there's a joint display, you might have heard of that before, and about bringing the quantitative and qualitative data together into a representation. Typically it can be a table, it can be a diagram or a figure, and that can be really helpful, particularly in really complex studies. So that doesn't actually tell you how to integrate, but it's thinking about how you might present it. So most of the integration ways are thinking about, do you qualitize the quantitative data, or do you quantify and quantify the qualitative data? And it's thinking about what your question is. And as Catherine said earlier, and she might chip in a minute, is thinking early about how you're going to do that and learning about that. Sometimes that's quite hard because you don't know what the data are going to look like until you've actually collected the data. But it's just being mindful of that as you go through the process. Catherine, I don't know if you want to add into that.
Yeah, I think somebody asked if it was best to put it at the start of the study, and I think probably the gold standard would be to have it already decided when you were deciding your study design. But as Laura said, you don't always know what your data is going to look like, and we didn't know that it was going to turn out that we'd have this particular issue with antibiotic prophylaxis, and so using the qualitative, we were able to explore that more. I think it also depends on the output that you want from the study. So in the first one that I presented, the aim was to try and improve the WHO posters for maternity settings if needed. And so we were able to ask quite specific questions because of that. So the integration using the framework, presenting the quantitative results and the qualitative results together, we could look and see, do they confirm what each other are saying? Are they contradictory to each other? Why are they contradictory to each other? And then using that to draw conclusions. And so we said in that design, the quantitative and the qualitative had equal weight, equal importance. They were just different ways of exploring the same question. And then in the other one, we were integrating as a way of explanation. So qualifying the quantitative data, and I presented that, I integrated that in a summary table to try and explain the findings that we were seeing in the quantitative.
We've also had a number of questions that I think are all around the area of sort of, how do you choose what approach you're going to take? How do you choose your mixed methods design? And so think that would be helpful to people if we can give a broader response around that. I see your cameras come on there, Linda. I don't know if you're happy to take that.
Yes, let me start. I think the kind of question you're trying to ask and get responses about determines what kind of mixed method design you're going to do. You're not going to it saying, okay, I want to use this design and then this is my question. You'd rather say, this is my question. What is the best way to get to this question? That's when you start to say, okay, do I need to, if I'm wanting to develop something, then possibly you're already saying you can't have everything else you want to do in one proposal. So therefore, maybe you're looking at a sequential design. Then you try to tease out to say, do I have enough knowledge to work with? If you have enough knowledge to work with, then obviously you can go ahead with your quantity study and do the explanatory and get the qualitative aspects, the minimum qualitative aspects later on. But if it's a newer area whereby you don't have enough information to work with to pull off a quantitative study, then that pushes you to say, okay, let me do an exploratory design first, whereby I understand what is really happening, what are the factors that are preventing, say, uptake of HIV services, if we don't have much literature over that. Then you do your exploratory, then you move to that. So pretty much it's a question that you want to answer. The information that is already available on the ground, that helps you to decide what design you're going to do. That's for the sequential designs. When I think of the convergent designs, you also look at what are the weaknesses of what I'm going to do now. Can it be supplemented or complemented by the other design as well? Like the example I gave about reviewing neonatal registers and postnatal registers. If I'd only looked at the registers, trust me, they look so clean because that data might not be very, very accurate. But if you bring in the qualitative aspects as well, so you also then know that, okay, there are still some gaps here and there. So the ability to know your area of research and do a very good background work does give you a lenience to say, okay, maybe I need to combine. I cannot just lean on one method, and maybe possibly this is the method I need to look at within the mixed methods platform. Thank you.
This is
Thanks.
Moses. Can I just
Please,
add a
Moses.
little bit? Yeah. So I think in addition to what Linda said about the question that you're asking, but also I think there's need for somebody to reflect on several issues. And one of the issues that was actually quite apparent from Catherine's presentation is that mixed methods are usually resource intensive. So you really need to think about that to say, do I have sufficient resources to do this kind of mixed methods? There is also another dimension of time, especially for people who are doing, studies like PhD. You are kind of constrained in terms of the time that you have as a student, and therefore you really need to think carefully whether or not do you want to use a convergent, mixed method design or a sequential, which maybe some of it might require you to have multiple ethics. So you also need to think about the time that you have. So those are some of the things that I wanted to just highlight. Thank you.
Thanks very much. And I think linked to that, we've had a number of questions that also seem to be around how fixed does one need to be? What are the times when one needs to, does one need to have planned everything up front? Or does this sometimes evolve over time? I think, yeah, no, Linda, please carry on.
All right. Okay, so it evolves over time. You can have thoughts to say this is the intervention we want to run with, but your data is going to surprise you with the interventions that are going to come up with. So it evolves over time. At one point in time, we're putting up a grant which is going to be mixed methods. Now that's a difference with funders. They would want you to still give a projection of like, what is your best guess in terms of like intervention that you're going to do? So the advice that was given then was to say, okay, you still put in the guess to say, this is the intervention that we are anticipating, but you put a disclaimer that it might change dependent on the data, because for a funder as well, I suppose the aspects of mixed methods is not also very much clearer. They would want something that is making sense. Similarly, with the IRB, you still put in to say that we're doing a mixed method study. This is the first phase. The second phase might look like this, but it's going to change over time as well. So you already put up that area of the element of change that is going to happen. So it evolves over time. Like for me, when I was doing the mixed method study looking at male involvement, I thought that by calling men to come to the clinic would be the most ideal intervention. I was surprised when they taught me that, no, don't call us, send us a letter in an envelope addressed to me. That's more respectful. Then I'll show up to the clinic. Thank you.
Thanks. Does anyone else have anything to add around that? I know, Laura, you've sometimes talked about, some of the, flexibility within mixed methods that you enjoy.
Yeah, definitely. I think that's something to embrace. I really like the fact it can do so many different things and provide such a much broader understanding. And I think Catherine's given some really nice examples of that, as well as other people in the group. Yeah, I think you've got to embrace that, but know that it can be tricky, and it can be tricky to get permissions for and to publish. But it is worth it. And I think that there is a shift in attitude around mixed methods. Definitely, it's a bit like the qualitative research historically was never as highly valued as quantitative, potentially. And I think that's when kind of moving towards that with mixed methods as well. I think it will potentially get easier to get through ethics as people's understanding around mixed methods develops, and around getting published, and bigger word counts to allow us to write more, because we do need to do that. So yeah, I think there's so many benefits of mixing. Doesn't mean it's easy, but there's so many benefits to it.
Can I ask what I think is another interesting question? We've just got a few minutes left. Referring back to what you were speaking about, some of those challenges around, for example, publication if you're using a mixed methods approach. Is it acceptable, was the question, to split manuscripts into the qualitative and quantitative components, and is that then still mixed methods?
For me, I find it really hard. If you've developed a study and as Linda really elegantly said, you have your question and then you decide what the best method is to answer that question. And if the answer is to use mixed methods, then I feel like we should really push to publish the mixed methods, because that was the aim of using mixed methods. If you publish separately, you're not getting the benefit of the integration, and that's not getting out into the public domain. So you can make reference to each of the papers and talk to each other, but it's just not the same. And then to me, that says if you can actually write it up and publish that way, it's maybe a multi-method study and not mixed method. So I would always push for mixed method. There are more and more journals publishing mixed methods, and it might not go into the journal exactly that you want, but I would absolutely be pushing for a mixed methods paper, because that's delivering what you set out to do. But others might have a different view on it.
So I've split before because I needed to have a paper that has published the strategies that I was going to make noise for the IRB to say, this intervention is really research-based and it's there and it's been published. So I had to split the papers to see that the one that specified the intervention should be a standalone paper, and the trial one should be another standalone paper, so that the trial should now refer back to that paper somewhere, somehow. But I agree with you about publishing it as mixed methods, but sometimes it's also hard to find journals that are going to accept that. Lately, I've seen that the new journal for the PLOS Global Health Journal, the new one, is much more keen to accept such type of manuscripts as well.
And you're right, Linda, it is dependent on what you're trying to do and what the messaging is. A lot of these studies are really complex with lots of things that you could publish. And if you're looking at one particular aspect, like say if it's something about this is what the intervention is, and so it does depend on the question. And as like you, I have published separately, but I think if we as the academics doing this kind of research can lead the way with publishing mixed where we can. I think that will help longer term.
Thank you so much. I think in the interest of time, I think we should close the discussion. But just to thank everyone again for such fantastic presentations. Great to hear about the BREED work, and also that sort of rare opportunity to get the insights of what it really felt like as a researcher doing it, as well as just the sort of polished product at the end. I hope that those of you who joined, who are new to mixed methods research now really feel that you understand what it involves, some of the different methodological approaches, and can sort of see why this paradigm is useful both to answer key research questions and, as Bijoy explained, from the perspective of implementers and policymakers, where this can fill an important gap. So yeah, thank you very much everyone for the great presentations, and Katie and Tista, thanks for the great organization, and everyone else for joining and participating in the chat and all the questions. I'm sorry we didn't get to go to all of them, but really appreciate your input, and we'll make sure that this video with Katie and Tista's help is available on the GLOW website, and references are too. Thank you very much for joining.
Thanks.